Perfect.
Well, welcome everyone to another one of the latest highlights in neurosurgical oncology webinars. Today, we have a great speaker, Dr. Philipp Karschnia. He's a neurosurgeon and clinical scientist in the Department of Neurosurgery at Friedrich Alexander University School of Medicine in Erlangen, Germany. And his interests are mostly focused on neurosurgical oncology and immuno-oncology. Dr. Karschnia earned his degree from Saarland University, and then after postgraduate training at Yale and Harvard, then he trained with Professor Thon at the Ludwig Maximilians University in Germany, and he recently followed Professor Oliver Schnell to the Friedrich Alexander in Erlangen, where he's currently faculty. His main interests are the oncological effects of resections across molecular glioma subtypes. Using large multi-center databases, he's focusing on understanding which patients may benefit better from more aggressive resections. And he's currently coordinating the multidisciplinary RANO-RESEC group, where more than 15 international centers have been collaborating to evaluate associations between external resection and outcomes. And his glioma research has been recognized thoroughly with many national and international awards, and it is our true pleasure. Thank you, Dr. Karschnia. We're all looking forward to your talk on the oncologic role of resection in gliomas. With a very nice name, Finding the Therapeutic Sweet Spot for Resection. Please go ahead, and for everyone in the audience, if you want to put your questions on the queue, and then we'll answer at the end. Thank you so much.
Yeah, thank you. Thanks for the kind introduction and for having me. And it's really a pleasure to present to you the work of our group on the oncological role of resection and gliomas. So when I put together the talk, I was digging through the literature, and I came across a case series which is almost 100 years ago. And already Walter Dandy and Harvey Cushing operated on patients with presumed primary brain tumors. And they noticed that in a subset of patients where really extensive resection has been provided, a very favorable outcome was observed. And while we as neurosurgeons and surgical neuro-oncologists have certainly moved away from such aggressive approaches as being depicted here, the oncological value of more extensive resection, at least in glioblastoma, has been shown across different larger retrospective studies. And there's a pretty nice meta-review being published in 2016 in JAMA Oncology, showing that most of the studies published in terms of external resection and glioblastoma favored more extensive gross total resection over subtotal resection when it comes to improving overall survival. However, what do we really mean when we speak about gross total resection, at least in glioblastoma? So what does this refer to? Is it the resection of the contrast enhancement? Is it the resection of the surrounding non-contrast enhancing mass-like tumor mass? Or is it resection of the entire T2 flare abnormality, which needs to be provided in order for a patient to experience a survival benefit from surgery? And does it differ between patients with newly diagnosed or recurrent disease? Does it differ across molecular glioma subtypes, and how much tumor we need to remove in order for a patient to experience a survival benefit? And in the coming minutes, I want to show you evidence what to resect in glioblastoma. So what should we focus on? Is it the relative reduction of the tumor? Is it a residual tumor volume? What evidence do we have for resection of contrast and also non-contrast enhancing tumor volume? Then I will move forward to also touch on recurrent disease, recurrent glioblastoma, and also IDH mutant glioma. And then I will give you a brief overview about where I believe our field is heading from an external resection point of view. So most of the studies which have described a survival benefit for more extensive resection in a glioblastoma have focused their definitions of gross total or subtotal resection on the relative reduction of the contrast enhancing tumor volume. And as you can see here, the definitions which have been applied dramatically vary across the different studies. And this would not be so much of a problem if the association between extent of resection and surgery is binary in outcome. So you have a cutoff point, you need to meet that cutoff point, and if you make it, the patient has a survival benefit, and if you don't make it, this survival benefit would be lost. But probably this is not the case. So in 2011, another Sanai published his landmark publication in Journal of Neurosurgery, where he stratified patients according to the relative reduction of the contrast-enhancing tumor volume. So how much resection has been provided? Was it 70%, 85, 90%, 95, and so on and so forth? And what he observed is that patients start to have a survival benefit once about 70% of the tumor has been, 70 to 80% of tumor has been removed, but also more extensive resection, so larger percentage being removed, translate to additional survival benefits. This has also been shown by other groups, such as the UCSF group, here in a publication by Annette Molinaro, published in JAMA Oncology in 2020, where you can see on the x-axis the relative reduction of the contrast enhancement. On the y-axis, you see the hazard ratio for death, and you can see an exponential increase for the hazard ratio for death for lower percentages of tumor being removed, and an exponential decrease for higher extents of resection. However, does it really make sense to measure extent of resection based on the relative reduction of the tumor? And does it not make more sense how much is being left behind? So if we take a very simple case and construct a case with an initial tumor volume of about 60 cubic contrast-enhancing tumor volume preoperatively, being left behind with a residual tumor volume of about 5 cubic, you would assume that this patient has experienced a substantial survival benefit from surgery, given that about 90% of the tumor has been removed. However, if you construct a similar case with a smaller preoperative contrast-enhancing tumor volume, but the same postoperative tumor volume at the exact same location, you would assume that this patient would have experienced less of a survival benefit, given that only about 60% of the tumor has been removed. But that doesn't really make sense. It's probably more important what has been left behind, measured as residual tumor volume. And with that, we started our kind of RANO-RESEC group. So this is a working group within the response assessment neuro-oncology framework. A lot of centers from the United States, but also from Europe and also from Asia collaborate in order to delineate the oncological role of surgery across different molecular subtypes, including glioblastoma. And we started with a very basic question. What matters more to a patient? Is it the relative reduction of the tumor volume, or is it the tumor remnant, which translates into more or less favorable survival benefit? On the upper left, you see a graph which depicts postoperative residual contrast enhancement on the x-axis. On the y-axis, you see the hazard ratio for death, and you see the hazard ratio for death goes exponentially up with higher residual tumor volumes. The plot next to it depicts the relative reduction of the contrast enhancement and the hazard ratio for death again on the y-axis, and you can easily see that the slope is way less impressive compared to the one on the left. And also in a multivariate analysis, which is being based on more than 1,000 patients with newly diagnosed IDH wild-type glioblastoma, you see that the relative reduction of the contrast-enhancing tumor volume lost its prognostic significance and overall survival, while the relative the absolute residual tumor volume retained its prognostic significance. And this is also in line with publications from post-hoc analysis of prospective cohorts, such as in the paper from Ben Ellingson published in Neuro-Oncology, showing that with higher residual contrast enhancement, overall survival decreases in patients with newly diagnosed glioblastoma. So it's the residual tumor which matters. However, do we also observe a survival benefit if we go beyond the contrast enhancing tumor margins. So if we provide a surgeon a supramaximal resection beyond the contrast enhancement. And when I speak about the supramaximal resection, I'm not referring to resection of the entire T2 flare abnormality, but only to the resection of the non-contrast enhancing mass-like lesion surrounding the contrast enhancing tumor course. So in the patient I'm depicturing here, this is a patient where we believe a supramaximal resection has been provided. And indeed, if we only look into patients with an IDH wild-type glioblastoma, in which complete resection of the contrast enhancement has been provided, and all of those patients being homogeneously treated with radiochemotherapy according to the STOP protocol, we see that with higher residual non-contrast enhancing tumor volumes, survival goes down, while at a cutoff of about 5 cubic non-contrast enhancing tumor volume and no residual contrast enhancement being left behind, we see a survival benefit. So this fuels the theory that there is a subset of patients which do benefit from a so-called supramarginal resection. And the survival benefit is really impressive. So when you compare patients with a supramaximal resection to patients with a maximal resection where the entire contrast enhancement has been resected, you would assume that the survival benefit is probably in the range of about 9 months. So this is quite impressive. And this cutoff of about 5 cubic non-contrast enhancing tumor volume has also been described by other groups, not only by ours, but also by, for instance, the UCSF team, which published their findings in JAMA Oncology in 2020. How can I convince you that it's really also the non-contrast enhancing tumor volume which matters in patients with glioblastoma? So to further convince you, we made use of a really peculiar patient cohort. Patients which were diagnosed with an IDH wild-type glioblastoma per WHO 2021 classification, but did not have any evidence of contrast enhancement on preoperative imaging. And those are 2 cases where I'm referring to. So in the upper row, you see a patient with a right temporal IDH wild-type glioblastoma. No contrast enhancement is being appreciated. And the same is true for the case depicted in the lower row. And those patients do identify with an overall survival, which is similar to patients with traditionally enhancing IDH wild-type glioblastoma. And we accumulated about 100 of those cases. In the lower left, you can see that the vast majority of those patients have been treated according to current standard of care for glioblastoma, so with radiochemotherapy in the first line treatment. So this is the wave which is going up. And after first progression, most of those patients were treated with chemotherapy, with or without resection. And when you stratify patients according to the residual non-enhancing tumor volume, you can also see that in those patient hazard ratio for death goes exponentially up with higher volumes of non-enhancing tumor volume. This is also being retained to be of prognostic significance in a multivariate analysis. So this peculiar subgroup of patients with non-enhancing glioblastoma underlines the theory that also the non-enhancing tumor volume matters in patients with glioblastoma. With that in mind, we proposed the so-called RANO categories for external resection, which establishes 4 different resection classes to standardize terminology when we speak about extent of resection. And those 4 resection classes, supramaximal, maximal, submaximal resection, and biopsy, rest their definitions upon the residual contrast as well as non-contrast enhancing tumor volume. And each of those 4 resection classes identifies with a distinct progression-free and overall survival. The validity of this classification system has been shown also not only by but also by other groups using external control data, and has been shown to be of prognostic significance also in other cohorts, not only ours. And what I'm really excited about is that these those RANO categories for external resection are already making it into clinical trial protocols. This is a trial protocol from Michelle Kim from Michigan. She's a radiation oncologist, and she's currently setting up a trial within the NRG Oncology Network, where she's proposing to extend the radiation field beyond the contrast-enhancing tumor on MRI based upon more advanced imaging, including PET imaging. And she's having different steps of the trial. That's what she's proposing. And this trial will also stratify for the RANO resect categories when including patients. So it's already being part of clinical trial protocols, and that's pretty exciting to see, given that we published our findings almost only 2 years ago. And what one can also make use of those RANO categories for is not only to stratify patients in the setting of clinical trials, but also to elucidate the interactive effects of surgery with other prognostic markers. So we did that in a very recent publication. This has been out for about 4 weeks, in which we looked at a group of about 770 IDH wild-type patients with a newly diagnosed glioblastoma, and we made use of recursive partitioning analysis to construct a decision tree. And this decision tree you are seeing here at the left individually weights the different prognostic factors, such as extent of resection measured by the RANO categories, but also postoperative KPS, age, MGMT promoter methylation status, whatever has been of prognostic significance on a multivariate analysis in this particularly patient cohort. And you can see here that you end up with different risk categories, which individually weights your prognostic factors, but it also tells you something about the prognostic effects of surgery. So the risk categories you're ending up is a risk model which is superior to other risk models, which have been previously published, but it also tells you something about the oncological role of resection. For instance, in MGMT unmethylated patient, you see a split in the decision tree for RANO class 1. So patients with an MGMT unmethylated status had a substantial survival benefit when a maximal resection has been provided. However, in elderly patients over the age of 65, this effect seems to be lost. And so this is something which certainly warrants for further evaluation in dedicated sub-studies. The entire decision, and this is something which is also which also is in line with our prospective studies. So, for instance, the very high value of more extensive resection, supramaximal resection in patients with an unmethylated MGMT promoter has already been shown in the data from Konstantin Roda. He published a paper in Journal of Clinical Oncology, which was a parallel cohort study comparing centers which made use of intraoperative MRI for resection of glioblastoma to centers which are using 5-ALA. And he was not able to find any difference in terms of outcome between the individual centers. So he showed no superiority of IMRI compared to 5-ALA. And he pooled all his data, and he looked at the influence of residual tumor volume on outcome. And he was able to show that the survival curves only split for patients with non-methylated tumors, while there seems to be no difference between patients with no and very small tumor remnants when the MGMT promoter methylation status is methylated. So there, the chemotherapy seems to take care of whatever has been left behind when the tumor remnant is not too large. So to conclude for newly diagnosed IDH wild-type glioblastomas, I hope that I was able to show you that it's a residual tumor volume which matters oncologically, that there's a continuous association. It's not only binary in nature, but there's a continuous association between residual tumor volume and overall survival. And it's not only the contrast, but also the non-contrast enhancing tumor volume, which matters oncologically. And the RANO-RESEC classification system offers a framework to standardize terminology when we speak about extent of resection and assess the interactive effects of surgery with other clinical markers. So what's the situation for patients with recurrent glioblastoma? So as you all know, the treatment algorithm for patients with glioblastoma is pretty much predefined in the first line setting based upon the clinical and the molecular patient profile. But once it comes to the recurrent setting, it's not really so well defined, and there are a lot of treatment modalities being used with no superiority of one being shown to the other in really a true randomized prospective study. So surgery is certainly one of them. And we collected a cohort of about 680 IDH wild-type glioblastoma patients, all of them previously being resected. And on the left, you see the 310 patients which underwent re-resection first recurrence. On the right, you see the 371 patients which did not undergo re-resection at first recurrence. And I don't want you to go through the entire table, which is or the entire data, which is being depicted here. But what I want to show you is that there was no difference between those two groups in terms of the molecular tumor profile, but also the external resection, which has been provided at first resection, and also not at the medical treatment following resection or re-resection. So most of the patients have been treated with radiochemotherapy as a first-line treatment, this wave going down, and the vast majority of patients has been treated with chemotherapy following re-resection or following first progression. And what you see here is that if you stratify patients according to whether re-resection has been provided or not, you see that patients in which re-resection has been provided seem to do better. This is also being retained when you stratify patients according to the MGMT promoter methylation status. However, I mean, I think it's fair to say that we all know that patients who undergo re-resection at recurrence probably just identify with more favorable clinical profile. They might have smaller recurrent tumor in a more benign location. They are clinically more fit. So those are patients who just tend to do better. However, even if we control for all those factors in a multivariate analysis, the effect of re-resection on outcomes still seems to hold true. But if you then stratify patients according to the residual contrast enhancing tumor volume, which is the plot in the lower right, and then compare those patients to patients in which no re-resection has been provided, only patients in which less than 1 cubic contrast enhancing tumor volume is being left behind seem to identify with a more favorable overall survival compared to patients in which only biopsy or no re-resection has been provided. So there seems to be a trend that only patients in which very aggressive surgery in terms of contrast enhancement has been provided, only those patients seem to benefit. And this is also true when you compute the plot I've previously shown you. On the x-axis you see the postoperative contrast enhancement. On the y-axis you see the hazard ratio for death, and you see an exponential increase for hazard ratio for death with higher tumor remnants for contrast enhancing tumor remnants. However, in contrast to the newly diagnosed setting, we were not able to find any evidence that supramaximal resection beyond the contrast enhancing margins translates into improved overall survival. There's no effect of the non-contrast enhancing tumor volume on the hazard ratio for death. The slope is not very steep. You don't see any difference between patients in RANO class 1 compared to RANO class 2. So there is no difference in overall survival and no evidence for supramaximal resection in patients with newly diagnosed disease and patients with recurrent disease. And why is that? So to elucidate the reason behind that, we stratified patients according to external resection, so RANO class 1 or 2. here on the left, RANO class 3 on the right side, depicted in red, and then we stratified patients according to adjuvant treatment provided. On the upper row, radio chemotherapy, middle row, only radiation, lower row, no further treatment. And you can see that in patients in which no further adjuvant treatment has been provided, the rate of new postoperative deficits was highest. This is being depicted here in the pie chart, and always the darker color is the rate of patients with a new postoperative deficit. And it's very tempting to speculate when you see those data that a high rate of new deficits in patients with a supramaximal resection has prohibited those patients to undergo further treatment and decreased their clinical performance status, and finally basically also neglected any effects of surgery. And this was also confirmed in a propensity score matched analysis. So we try to minimize confounding effects by computing propensity scores and basically mimicking a randomized controlled trial. Again, here you see minimization of the confoundings being depicted here in the left at the kernel density plots. You see that those curves are splitting, showing a survival benefit contrast enhancement, but again, no survival benefit is seen for supramaximal resection over patients with a maximal resection. So what we would propose from a surgical decision-making standpoint would be to only go ahead with re-resection if you assume that you can take out all the contrast enhancement. At our center, we also discuss re-resection for patients in which we believe that surgery may improve symptoms, which we attribute to mass effect. However, from an oncological standpoint, if we believe we cannot get out the vast majority of the contrast enhancing tumor, then we would not go ahead with re-resection at first recurrence for those patients. So, and this is exactly how we would manage the patients I've been showing you at the very beginning in patients with a newly diagnosed disease. The aim is certainly to provide an aggressive resection, supramaximal resection, as being shown here with only very minimal amounts of residual non-enhancing tumor volume on the left. However, in patients with recurrent tumor, you aim to get out all the contrast enhancing tumor, but we usually tend to not touch the non-contrast enhancing tumor volume given the substantial risk to deteriorate the patient's clinical performance. So I talked a lot about IDH wild-type tumors, and this is certainly what I wanted to spend the most of my time with. However, I just want to give you a very brief overview about what is there to win for us as surgeons in IDH mutant gliomas. So you all know that all the guidelines, this is the European guideline for managing patients with gliomas, recommend maximal safe resection for patients with IDH mutant astrocytomas or oligodendrogliomas. And this recommendation is based, or in large part based, on a study which has been performed by Asgeir Jakola in Norway. And the way how the health system is being set up in Norway is that patients present to the hospital where they are living at. So patients are usually not traveling. And Asgeir compared a center which usually provided more aggressive resection in patients with presumed low-grade gliomas, while the other center at the different end of the country usually went ahead with biopsy only and did not provide a meaningful resection to those patients. And what he was able to show is that the patients who presented to the center favoring resection tend to do better over years and decades. And this is also true if you stratify patients according to the molecular tumor profile, according to the WHO 2021 classification. So also the survival curves for IDH mutant astrocytomas split after about 2 to 3 years, and oligodendrogliomas, they split after 5 to 7 years. And this has also been shown in other studies that the effects of resection on IDH mutant astrocytomas seems to start very early after resection, after a couple of years, while in oligodendrogliomas takes a little bit more time. So Is there also evidence for a supramaximal resection, IDH mutant gliomas? There was not a lot of literature out there until last year when the UCSF group published a very prominent paper in Journal of Clinical Oncology, where they defined gross total resection plus, so resection beyond the imaging defined tumor margins. And they showed that in the uncorrected cohort of IDH mutant gliomas grade 2, there was a benefit for gross total resection plus. However, while this was retained for patients with IDH mutant astrocytoma, there was no evidence for patients with oligodendroglioma. So it's not really clear whether supramaximal resection is only of benefit for patients with astrocytomas or whether the sample size was just too small to see any evidence for oligodendroglioma patients. And I think the final call is still out there, particularly given that there's an Italian group which published also on supramaximal resections, a group of Marco Rossi and Lorenzo Bello. They put together their cases and they showed that also in patients with oligodendrogliomas, there seems to be a benefit of supramarginal or supramaximal resection over maximal resection. That's a plot on the lower right. However, it's really kind of puzzling while the event rate is so high for the patients in which maximal resection, but not supramaximal resection has been provided. So I think the final call is still out there. So to conclude regarding the risk-benefit ratio of surgery across molecular subtypes, in IDH wild-type glioblastoma, we have a couple of months to use to win when we provide more extensive supramaximal resection over submaximal resection. However, we have a lot to lose. If we induce new deficits, then we probably neglect all the benefits we had from more extensive resection. In oligodendrogliomas, you have a lot to win from surgery, but it takes years to decades for those effects to unfold. However, in IDH mutant astrocytomas, those effects are certainly more pronounced. Those are patients where you can win a whole lot of life years, and where you would also be willing to maybe take a small risk and tolerate also a mild deficit, because those are patients who have time to recover from their deficits and really, really, really benefit from more aggressive surgery. So what's the direction we are going to as surgeons? Know that Christmas is coming. I have a couple of wishes where I hope we are moving towards. So one is to add another level of granularity when we speak about how to identify patients where we should provide a more aggressive resection. One example is a study by Richard Drexler, which was published in Nature Medicine a couple of months ago. And he showed that the epigenetic tumor profile, so neural high or neural low profile in patients with glioblastoma, seems to affect the success of surgery. So in patients with neural high tumors, those are patients who substantially benefit from supramaximal resection and the disconnection of the tumor and of the infiltration zone of the tumor, while in neural low tumors, this effect was not seen. So maybe we are moving towards novel biomarkers to guide resection, maybe even during surgery. So this is something which would theoretically also be available by novel histopathological and epigenetic methods within minutes to a couple of hours. So this is information we might have during surgery over the next years. And we may even move towards a molecular quantification of residual tumor at the margin. So if you take a predefined samples at the border zone, this was what a group from MGH was doing. They sampled the border zone in patients in which complete resection of the contrast enhancement has been provided, and found that in patients with clean molecular margins, so no evidence of third promoter mutations left behind in that morphologically unaffected tissue sample, those patients tend to do better and have better local control compared to patients where the molecular margins were still dirty and third promoter mutations were still to be detected. So to summarize, I think we as surgeons can benefit patients with both newly diagnosed and recurrent glioblastoma. However, judicious patient selection is certainly the key for success and also for nuanced surgical decision making. Standardization matters, or both for reduction of imbalances in clinical trials, but also for assessment of the role of surgery across molecular subgroups of tumors. And from a future direction perspective, I believe we are moving towards real-time feedback of tumor cell infiltration and guidance of our surgical approach based on molecular characteristics. And with this, I want to close. I want to thank, of course, you for the kind invitation and all of our collaborators in the setting of the RANO Reset group. Thank you so much. Looking forward to hear your questions.
Thank you. This was fantastic, Philip. I really appreciate it. I know it's late in Germany, but this was a very nice overview. I have a couple of questions, and obviously most of the assessments of these patients don't include higher neurocognitive function, right? That you would not see, except for an obvious deficit of primary eloquent cortex, language, vision, motor deficits. And also, just if you can touch upon the percent of patients that could potentially get a supramaximal resection is very low, less than 20%. So for the young surgeons that are there starting the practices, got to be cautious on potentially hurting patients. So if you want to say some of that, what are your thoughts on that?
Yeah, so absolutely. I think that's a great point. So neurocognition, I think it's super important. I think for patients with IDH wild-type glioblastoma, I would be a little bit more cautious to place too much weight onto very sophisticated neurocognitive testing, given that those patients probably will deteriorate anyway within a couple of months, and they usually really, really benefit from the months they are gaining in terms of mere overall survival when you're providing a little bit more of a meaningful resection without inducing a very severe, like a motor deficit. In patients with IDH mutant tumors, I absolutely agree. I think what we really need is a prospective control trial to see whether a more extensive resection, potentially leading to like some sort of higher level neurocognitive deficits, whether those patients do worse compared to patients in which less extensive resection has been provided, particularly given that patients where you would assume you provide a less extensive resection, those are the patients who might have earlier recurrence and eventually become earlier treated with radiation therapy, which also has neurocognitive consequences. So I believe, particularly in the IDH mutant glioma subgroup, those are patients where a control trial is really, really needed with a standardized setting, standardized measurement of neurocognitive cognitive function. I absolutely agree. And I think from retrospective data, which is the data I've shown you, but also post-hoc analysis of prospective data, I think it's really hard to get those nuances and to get a feeling for neurocognition. In terms of the rate of patients where you can actually achieve a maximal resection, I absolutely agree. It's not a whole lot of patients. It's, as you said, probably something between 15 to 20%, depending on which cohort you are looking at and which clinical setting. And the recurrent setting is certainly lower, but in a newly diagnosed glioblastoma setting, probably 15 to 20%. However, considering that the survival benefit we believe we can offer is somewhere in the range of, let's say, 9-10 months, this is really meaningful for a lot of patients. I mean, all the chemotherapy, the radiation therapy we are providing to patients, those prospective studies have yielded a survival benefit of 2, 3, 4 months, not more. If we as surgeons can provide 9-10 more months by just providing a more meaningful supramaximal resection, I really believe this matters and even if it's just for those 10 to 20% of the patients.
That's
Thanks, Philip, for the great presentation. Ashish, I'm one of the junior investigators here in Miami. I love the talk. I think, amazing figures. My main question to you is, two things. One is, there's like a Korean group, and here in Miami, some of our investigators also, some of our surgeons, favor like lobectomy. Just, if you have a lesion in the right frontal lobe, just, go do an anatomic lobectomy, right frontal lobe, right temporal lobe, occipital lobe, and for these IDH, wild type GBMs, and it offers two things. One is you definitely get the contrast enhancing lesion from, for these cases because it's anatomic, and then you definitely get the flare around it. And they've seen some benefits in overall survival. Do you think that, that getting that extra non, I guess that flare, resection? I know you showed some of that data. Do you think that is added benefit in the lobectomy cohort, or is there just a limit to the kind of the benefit of the extra normal brain you're taking?
I think there's probably so I would take the studies I'm aware of comparing lobectomies with colpectomies in patients with contrast enhancing glioblastoma. I think they've continuously showed a kind of survival benefit in a retrospective cohort for the lobectomy patients. However, I do believe there is certainly also some bias regarding, patient selection, patients where you would consider a lobectomy are probably the patients with a more circumscribed disease, patients which are clinically more fit, more benign location, where you would even consider a lobectomy. I do think that we reach probably an asymptote somewhere when probably you don't need to provide a too extensive resection. My thought is that just going beyond the mass-like non-enhancing tumor surrounding the contrast enhancement, I think this is probably enough. But excitingly, we started in Germany a prospective controlled randomized trial. The PI is Matthias Schneider. He's from Bonn, and he's doing exactly that. It's called the Atlas trial, and he's comparing patients to undergo either standard of care contrast enhancing resection or per institutional standard, also supramaximal resection to lobectomies. And this trial has just been started to recruit a couple of months ago, but I believe we will have the answer in probably 3 to 4 years.
Great. Awesome. That's great to hear. And then the last question I had for you was regarding these TERT promoter mutation tumors that are non-enhancing, they look low grade, they have TERT promoter mutation, but they're GBM molecularly. I feel like they behave a little bit less aggressive than IDH wild type contrast enhancing lesions, but obviously more than a typical low grade because we can classify them as GBMs. Is the extent of resection, of those lesions, is there any difference there? I guess.
So they do behave different. I absolutely agree. The overall survival in our uncorrected cohort was, I think, about 28 months, which is a little bit more what you would expect for patients with typically IDH wild type contrast enhancing tumor. Nevertheless, probably the way how I think about those tumors, I would assume that the margin those patients tend to live longer is probably just the time it takes for those tumors to really pick up speed and start to enhance. So if you follow those patients, and I had a couple of those patients where we thought, okay, it might also be a low-grade tumor, and then we scanned them after like 6 weeks or 3 months, and then it kind of exploded, and the contrast enhancement was everywhere. And then they really start to behave like a typical IDH wild-type glioblastoma. So I think those are just glioblastoma patients which you kind of picked up earlier. I know that there's also some controversies around that. Some people think different about that, but that's how I feel those patients are. And frankly, in line with that assumption, the role or the gains from more extensive resection was pretty similar. So the relative gain was pretty similar to a standard enhancing IDH wild-type glioblastoma.
Thank you.
Wonderful. Well, I appreciate everyone. We're going to continue with our next webinars in January. So everybody, happy holidays, and thank you so much to everyone, the AANS and the CNS, and Ankush and Ashish and everyone who's really helping organize this. So thank you, Philip, and hope to see you guys soon next year.
Yeah.
Thank you.
Thank you.
Really appreciate it. Happy holidays.
Happy holidays.
Take care, you too as well.